Welcome to the AETCM Emergency Medicine channel. Today we will be discussing regarding drowning and submersion injuries. So let's go into the definition. So as defined, it refers to the primary respiratory environment impairment of an individual due to submersion in a liquid medium such as water. It's a simple definition. Refers to a primary respiratory impairment of an individual due to submersion in a liquid medium such as water. It is otherwise called as submersion injury. So when you will suspect drowning when an individual is rescued following water submersion with following signs such as altered sensorium, cough or pulmonary rales on auscultation, hypotension or shock, hypoventilation or absence of pulse. So basically whenever you have decreased perfusion to the organs, to the brain, it can cause altered sensorium. When the excess fluid get accumulated inside the lung, you will have pulmonary rales and auscultation, which is in turn due to the pulmonary edema, hypotension or shock, hypoventilation or absent pulse. So this will be the spectrum by which the patient can present to you. So we will suspect when drowning when you see following signs. Now there are a lot of synonyms that has been used previously, and ILCOR, that is the International Licensing for Circulation Guidelines, suggests drowning to be used in place of previously used terms including dry and wet drowning, active and passive drowning, silent drowning and secondary drowning. So there was a lot of terminology that has been previously used, but ILCOR has made it mandatory that this synonyms should not be used and only the term drowning should be used, and terms such as near drowning, dry or wet drowning, active and passive drowning, secondary and delayed onset of respiratory distress should not be used. So this is the definition, and you should be using the terminology drowning or maybe a submersion injury. Now, as you know, the adult chain of survival for the cardiac arrest for the in-hospital and pre-hospital. Similarly, we have got a drowning chain of survival which is been represented here. You can see prevention of drowning, that is the most important priority. Like when you see cardiac arrest, you have to prevent the cardiac arrest for an in-hospital scenario. You would have a meeting, you post-resuscitation meeting, everything like that. So first most important thing is to prevention of drowning, that is the first thing, and recognize distress. Somebody is in distress and ask someone to call for help. If somebody is around, you have to call for help, and provide flotation, that is the next thing. So whenever there is a high chance, maybe a swimming pool, maybe a beach, so all these equipments, the preventive equipment should be made available to prevent submersion injury. And as soon as the patient is drowning or he has gone into submersion, removal from water is the first priority that you have to immediately rescue him, but make sure that you yourself are safe. You know swimming and you are an expert enough to do that, then only go ahead and do. Otherwise the expert personnel should do, and provide care as needed and seek medical attention. So this is a simple chain of survival for drowning. So you have the prevent drowning, be safe in and around water, recognize distress, ask someone to call for help, provide flotation to prevent submersion, remove from water only if safe to do so, and provide care as needed and seek medical attention. So that is the drowning chain of survival. Now, what are the likely risk factors for drowning? There are a lot of likely risk factors for drowning. The most important ones are males, age less than 40 years, low socioeconomic status, poor education status, living in rural areas, epilepsy, it is associated with around 15 to 19 times risk, substance abuse, trauma, exacerbation of existing cardiac diseases, syncope, attempted deliberate self-harm, exposure to water, leaving kids unattended near water. So as we told previously, the most important part is the prevention. So you see the vulnerable group population like children, they are more prone to develop the submersion injury when they are kept unattended near water for a long time. So that should be avoided. So these are the likely. Now there are certain associated conditions following drowning which the patient can have. The most important one is the primary one is the hypothermia. You can have primary as well as secondary hypothermia. What is primary hypothermia following drowning? It occurs rapidly due to submersion into icy water less than 5 degrees Celsius. Secondary, it is due to subsequent heat loss through evaporation during resuscitation attempt. So this is primary hypothermia and secondary hypothermia, and there can be associated trauma, and we have said seizures, which has got a high risk factor for drowning. Now let's see what are the causes and what exactly happened during drowning. Submersion in a liquid medium resulting in a liquid bar air interface at victim's airway that prevents breathing. So that is the primary culprit. So there is an interface where the liquid will go and interfere with the water, interfere with the air, and as a result the victim stops breathing or it interferes the breathing, and there can be associated seizures. And there are certain conditions that may cause loss of consciousness that may precede before drowning. For example, the patient had an LOC and he had a drowning later after that. So example, the most important one can be an hyperventilation syndrome. Suddenly due to panic, the patient is hyperventilated and he had lost consciousness and he had a drowning, or concussion injury, stroke, cardiac arrhythmias and major trauma. So these are the conditions that may cause LOC that may precede before drowning. Now coming to the pathogenesis as such. So what happens after submersion? Victim holds breath for less than 1 minute before developing laryngoscopism. So that is the first step that will happen. Victim holds breath for less than a minute before developing laryngospasm. Further, victim then frequently swallows larger quantity of water. That is the next step that is going to happen. And continued breath holding and laryngospasm result in development of hypoxia, hypercapnia and acidosis. So that is a major culprit. You understand that continuous breath holding and laryngospasm will start developing, resulting in development of hypoxia, hypercapnia and acidosis. And when reflux abates, the aspiration of water will happen into the lungs, and amount of aspirated water decides the degree of hypoxemia. So let's see what happened. Once again, after submersion, victim holds breath for less than 1 minute before developing laryngospasm. Then victim frequently swallows larger quantity of water, and continue breath holding and laryngospasm result in development of hypoxia, hypercapnia and acidosis. And when refluxes are abolished, aspiration of water into the lungs occurs, and then amount of water aspirated decides the degrees of hypoxemia. Now, what are the other lung injuries? One lung injury what we have described is the basic problem with the ventilation perfusion mismatch. Let's see what are the other. And as I told, the amount of water aspirate decides hypoxemia, surfaction dysfunction or washout of complete surfactant, alveolar collapse can occur. Alveolar collapse further result in exacerbation of fluid, plasma and electrolyte shift, and pulmonary edema. Again, one of the deadliest complications is the pulmonary edema. What is the pathophysiology? In fresh water, due to the permeable alveolar capillary and transient hypovolemia, pulmonary edema occur. In salt water, due to osmotic gradient diving fluid into the alveolar capillary. So you have to pathogenesis is a little bit different for pulmonary edema in fresh water and salt water. And reduced respiration. Further, the patient will victim will have decreased respiration, which result in atelectasis, intrapulmonary shunting, decreased lung compliance, and finally the ventilation perfusion mismatch. So these are the lung injuries that can happen further following your drowning. So we have said the pathophysiology and what exactly happening to the lungs, and finally bronchospasm also. So if no rescue bar ventilation is happening within the time frame, hypoxemia will lead on to loss of consciousness, apnea and multi-organ dysfunction, further into cardiac arrhythmia, pulseless electrical activity and asystole. And there can be additional effect on respiratory system like impaired gas exchange, injury to alveolar capillary membrane directly itself, and later on a secondary lung infection. Now effect to the CNS, basically it causes cerebral hypoxia, and there can be raised intracranial pressure also resulting cerebral edema also, which we will discuss and how to manage that also. And hematological, there can be hemolysis occur due to profound hypoxia. So you have to understand that vast majority of drowning victim, more than 98%, reported to aspirate water. So lack of water in lungs on autopsy suggests other cause of death. So when you have somebody as a forensic expert is evaluating and he says that there is no water inside the lungs, you have to consider some foul play, or maybe he would have died before drowning. The cause of death is not due to drowning. So there is a grading system of drowning as per symptom severity. You can see grade 1 to grade 6 symptoms. First you can see the response to stimuli. From grade 1 to grade 4 there will be response to stimuli, and in physical assessment, grade 1 normal pulmonary auscultation with cough, grade 2 abnormal pulmonary auscultation with rales in some lung fields, 3 abnormal pulmonary auscultation with rales in all lung fields with normal blood pressure, grade 4 abnormal pulmonary auscultation with rales in all lung fields, that is pulmonary edema with hypotension or shock. It is just similar to our Phillips classification that we use for the pulmonary edema in acute coronary syndrome. And grade 5 is pulse present after auscultation or rescue breath, 6 pulse absent even after rescue breath, submersion time less than 1 hour without obvious physical evidence of death. That is obvious physical outcome that what we expect is that there is no rigor mortis, livor mortis, or there is no decomposition. That means if the submersion time is less than 1 hour, because of the hypothermia, the chance of developing rigor mortis is less. So if even at all, if it is resuscitated within less than 1 hour, you can try resuscitation. So that is the idea behind it. So that is the grading of drowning as per symptom severity. Now coming to the management aspect, which is the most important. As you know, any emergency, how will you tackle? That is the stabilization of ABCD. But here the priority is stabilizing the airway, breathing. That is the priority, because the primary reason that is happening in drowning is due to your problem with your airway and breathing, specifically to breathing also. So let's see what all things needed to be done. Assess for response to verbal and tactile stimuli. If no response, assess for adequation, ventilation and pulse. Remember your BLS algorithm that applies good here also. So the same BLS algorithm you should be remembering. If response, auscultate for rails. Consider all the rescued victim as a trauma victim, because we doesn't know how maybe he had an RTA and he was thrown out of the vehicle, or maybe a suicide attempt. We exactly doesn't know. So consider them as a trauma victim, and you need to keep in mind regarding the cervical spine injury. We will discuss how to do the cervical immobilization in the later part of the video. And clearing airway and maintaining patency in airway, that is the most important. You have to maintain an airway and patency of the airway and clearing of the airway. And in breathing, respiratory rate, saturation, look for pulmonary rails and role of advanced airway and definitive airway. If at all, back mask ventilation, continue your positive back mask ventilation, circulation, heart rate, BP, and look for arrhythmias. That is very important in a patient, especially hypothermia. The patient will be having prone to develop various sort of arrhythmias. Then GCS less than 13, that is again one of the indication for a definitive airway. And in children, look for the AVPU score, and in all patients, look for the pupillary asymmetry and look for any evidence of head injury. And most importantly, prevention of hypothermia and early rewarming is the key, and core body assessment ideally by the esophageal probe or epitympanic sensor. So that is the recommendation. So possible core body temperature should be measured by the help of a esophageal probe or a epitympanic sensor. So to the investigations, what all investigations that you need to send. The most important one, when the patient arrives to your ED, will be your ABG. Look for the evidence of hypoxia, hypercapnia or metabolic acidosis. Complete blood count. Again, if there is prolonged hypoxia, there can be hemolysis. Electrolytes, all electrolytes, sodium, potassium, to be very specific. Chest X-ray, look for the evidence of pulmonary edema. ECG, you can look for the hypothermic changes, that is the J point elevation, Osborne wave, and look for arrhythmias, bradycardia, premature ventricular contractions, ventricular fibrillation, prolonged PR bar QTC bar QRS complex. So these all things can happen in your ECG. And CT brain is warranted if you suspected a head injury following drowning, and definitely the role of your point of care ultrasound to assess your LV function as well as the fluid status of the patient, and maybe an early picking up of your pulmonary edema with your ultrasound probe. And also a tox screen is warranted, because whether the patient was under any influence of alcohol or not, we are not very sure. So tox screen, or maybe he might be on some anti-epileptics, whether he has overdosed or maybe subtherapeutic dose. So you may need to send the drug levels also, RFT, creatine kinase and cardiac biomarkers. And later on, you need to think in terms of bacterial culture, especially tracheal and blood, and EEG later, maybe to look for the evidence of hypoxia if there is cerebral hypoxia. So these are the nutshell investigations that you need to send from the ED. And this is the classical ECG representation showing you the Osborne wave. You can see the J point elevation and how the J point is elevated and changed as the J point elevation, which is seen in which is called as Osborne wave, which is seen in hypothermia. Now coming to the priorities in management. What are the priorities? Recovery and stabilization of adequate ventilation, oxygenation and perfusion. So that is the key here. And recover victim from water and begin immediate resuscitation. So to try to recover the victim as early as possible and begin immediate resuscitation. Maintain patient in vertical position during water recovery and supine position on land. Spinal immobilization, again spinal immobilization should be considered when you know exactly the mechanism of injury. As I told, it is following an road traffic accident, so there is a high chance of cervical spine injury, but do not delay recovery from water, and spinal immobilization may not be indicated if mechanism of injury by history is very clear. So you already know that what has happened exactly. Maybe by knowing the mechanism and by the history, you should not delay the recovery from water for spinal immobilization. So consider resuscitation effort even if patient submerged for a longer period if hypothermia is present. So role of prolonged CPR, that is one area. So as I previously mentioned, if it is less than 1 hour and there is no evidence of rigor or livor mortis, you can consider your prolonged. Now coming to CPR. So when we talk regarding cardiopulmonary resuscitation, as per the 2000 and whatever the changes has happened, the CAB of CPR, but here it is the ABC because the primary cause is to your airway and breathing. So traditional approach of airway, breathing, circulation approach should be used here, and start ventilation rather than circulation, airway, breathing. So that is one change where we will use ABC. And back mask for respiratory distress or respiratory arrest and continue CPR. Then who are submerged for 60 minutes and lack obvious physical evidence of death. As I previously mentioned, no rigor, body decomposition, livor mortis, you continue your CPR. Compression ratio again 30:2, 15:2 in case of a pediatric when you have more than one rescuer. No abdominal thrust or Heimlich maneuver, which should not be done at all, which is wrongly practiced. Drive victim before using an AED. Again, that is the most important thing because you have to make sure that you yourself is safe before using an AED or defibrillator. So drying the victim properly before you are using an AED. And ventilation, if no observed breathing, there is no breathing after rescue, give 5 rescue breaths instead of 2. So primarily here, as I told, the problem is within your A and B. So you give 5 rescue breaths instead of 2. If available, supplement rescue breaths with oxygen. So if oxygen is available nearby, you supplement the rescue breaths with the help of oxygen. Now coming to ventilation again, there are these are all ILCOR guidelines and BMJ position paper what I am discussing. So there are certain changes regarding ventilation, so we have to be careful when you are going through this video. So if victim is in shallow water, start rescue breathing if safety of rescuer is not compromised. So in the chain of survival itself we have told, if victim in deep water, the victim is in a deep water, open airway, and if no spontaneous breathing, start in water rescue in breathing. That should be done only with the trained hands. So a normal EMT might not be trained in this, or a normal rescuer may not be trained. So who has specialized training, who has got that aids only will be able to do so, and give 10 to 15 breaths over 1 minute. And if victim is less than 5 minutes from land, so the drowning has happened and the victim is just 5 minutes away from land, continue rescue breathing while towing also. And if victim more than 5 minutes from land, give further rescue breaths for 1 minute and then transport to land as quickly as possible. So if the distance from rescuing will take more than 5 minutes, you give 1 minute continuously breath and then transport to land as quickly as possible. And recovery position suction should be done if stomach contents start regurgitation. So that is the to prevent further aspiration. Already there is a high chance that while doing compression or while rescuing also the patient can regurgitate and it can further aspirate. So that should be prevented. So coming to the most important part, as I told, is the airway and breathing management. Patients who are protecting the airway with mildly labored breathing. So here the airway they are protecting, but they have got labored breathing. They can be started with oxygen by face mask at a rate of 15 liter, ideally by a non-rebreathing mask, with a goal of SpO2 between 92 to 96. So that is our target, 92 to 96. They are mild, only there is mild labored breathing. If the patient ventilatory status, mental state or saturation decline, go ahead and do an endotracheal intubation. Don't wait here. Go ahead and do an endotracheal intubation. Patients who are protecting their airway with increased breathing effort, requiring support, and who are maintaining sufficiently to follow commands may be trialed on a non-invasive positive pressure ventilation, but again there is a higher risk of aspiration. So what we suggest is that less than GCS 13, it is better to go ahead and intubate because already they have aspirated. Now again you don't want to increase the risk of aspiration. The patient does not improve, again there is clinical intubation, continue to the endotracheal intubation. Patients not protecting their airway or not performing adequate ventilation should be oxygenated via mouth to mask or back mask ventilation as a bridge to endotracheal intubation. So you don't have your endotracheal intubation, it is getting delayed. So go ahead with your back mask ventilation. If endotracheal intubation is performed, a mechanical ventilation should follow ventilation strategy similar to that of what we use in ARDS. So low tidal volume, high PEEP. So we will discuss that. If ETA equipment is not available, you don't have any endotracheal tube with you, or airway assessment suggests that ET is likely to be difficult, a supraglottic airway devices can be tried. So extraglottic devices can be tried, but if the supraglottic device does not result in sufficient ventilation, remove the device and continue with your bag mask ventilation. So what holds the important thing, if you have an ETI, endotracheal intubation, go ahead, otherwise go ahead with your positive pressure bag mask ventilation. So that is equally good. If advanced care facility is very nearby and bag mask ventilations are adequate to maintain an SpO2 of more than 95%, it can be continued as a bridge to ETI at the advanced care center. So till the center, you reaching the center, you can continue with the bag mask ventilation. So the key message is that those who are not protecting the airway, go ahead and intubate as early as possible. If you are able to do that, well and good. If you don't have that equipment, you can try an extraglottic device, but bag mask ventilation is equally effective. So during transportation and in ER, because why I am saying during transportation and ER is that during transportation also you need to continue the resuscitation. Once the patient reaches the ER also, the management is almost the same. Monitor vitals. Most important, oxygen target of 94 to 98%. Ensure optimal oxygenation before endotracheal intubation. So already there is hypoxia, so you have to pre-oxygenate very well. And cricoid pressure can be used to prevent aspiration. So cricoid pressure again in RSI it has been removed for routine use, but in this situation where you are suspecting high chance of aspiration, you can still go ahead with your cricoid pressure. That may have a difficulty for your intubation, but cricoid pressure holds good, and suctioning the airway with a proper Yango suction device is again one of the most modern priority. And set an FiO2 to target an SpO2 of around 94 to 98%. So that should be your target after the endotracheal intubation, and PEEP should be 5 to 10 mmHg. Titrate PEEP accordingly to maintain an SpO2 or a PO2 more than 300. That is the initial setting, but later on you can decrease on your FiO2 as well as your PEEP. So what you have to remember is that lung protective ventilation similar to that of ARDS, that is a low tidal volume, high PEEP, tidal volume less than 6 ml per kg. So that will be your strategies. Then most important thing is that you have to understand what is a respiratory arrest and what is a cardiac arrest, because it will be difficult to differentiate it, because in this victim difficult to palpate the pulse. So with the ED you have a facility of an echo mission or an ultrasound, you can go to the carotids and see the CASA protocol, but in certain scenarios it will be difficult. So use an ETCO2 if it is available, continuous ECG monitoring, these all things should be done, and prevention of hypothermia again holds good while you are transporting the patient. So now coming to the cardiac arrest, there are certain consideration from the routine ACLS management. Once cardiac arrest is management, apply the basic life support and ACLS, whatever the recommendation you have to do, go ahead. Rewarm the patient as fast as possible. If the patient is hypothermic, rewarm the patient as fast as possible. As possible, rewarming is the best antiarrhythmic and inotrope in this situation. So rewarming the patient is the priority. Look for and treat comorbidities and consider alternative diagnosis. Don't just think that it is due to hypothermia. There are other causes of cardiac arrest also, other H&Ts also you should be thinking. Anticipate a prolonged resuscitation that could require significant multi-specialty unit. You need to have a prolonged CPR, so you need to get an extra. Now coming to defibrillation and pacing, defibrillation is less effective in hypothermia. So for VF and VT, defibrillation may be tried up to 3 times, but is then not tried until the temperature reaches 30 degrees Celsius. So once it reaches above 30 degree only, you will start trying the defibrillation. Pacing is generally ineffective. Do not try it unless bradycardia persists when normothermia is reached. Sinus bradycardia may be physiological response and is not treated. Now coming to the resuscitation drugs are often indicate ineffective and will undergo reduced metabolism. So these are withheld below 30 degrees Celsius, then given with twice the time interval between the doses until normothermia is approached or circulation is restored. So less than 30 you withhold the drugs, above 30 maybe every you give epinephrine 1 mg every 3 to 5 minutes routinely. So here you can wait like 8 to 10 minutes, twice the time of normal you can wait till the victim has become normothermic. So adrenaline would be given about every 8 to 10 minutes once the core temperature is above 30 degrees Celsius till normothermia is achieved. Once normothermia is achieved, the regular resuscitation protocol, that is epinephrine every 3 to 5 minutes you can continue. Now coming to the rewarming, can be passive or active, that is internal or external. In patient with perfusing rhythm, passive measure may be sufficient. Passive measure will only achieve rewarming in a patient with effective circulation. So remove wet clothing and dry the patient, cover the patient head, ensure a warm environment, cover the patient with a blanket. A forced air warming blanket like a bear hugger will be more effective in this scenario. Now coming to what are the other medications that you need to consider. Broad spectrum antibiotic, yes. Because as you know, the water can be contaminated, we exactly doesn't know. So you can start with a broad spectrum antibiotic, maybe third generation cephalosporin to start with, or an anti-pseudomonal penicillin, or a carbapenems to start with, and you can, depending upon the patient scenario, you can decrease the antibiotic, de-escalate further after your culture and sensitivity, and also consider for the anaerobic coverage and antifungal depending upon the where exactly the patient has drowned. Consider antifungal and anaerobe, that's what I have mentioned. Again, clindamycin will be the drug of choice. Treat bongorbasum with your salbutamol multi-dose inhalers or nebulizers. Surfactants replacement has got less evidence. Cerebral resuscitation again has got less evidence with barbiturates. Phenytoins for seizure as it has got less sedative effect, because you wanted to see how the patient is recovering. So phenytoin can be used as a drug of choice, but again, cardiac arrhythmia, you have to be careful when using phenytoin. Preferred fluid of choice is 0.9% saline. Don't use hypotonic saline, should be avoided. And electrolyte management, sodium, potassium, and all your electrolyte management has to be done. Now other strategy, ECMO. There are multiple studies which showing the ECMO has got because you have got some time for resuscitation in the ED, because till the normothermy is achieved will be resuscitation. So ECMO definitely has got a role in drowning, and ICP monitoring is warranted. If you suspect a raised ICP, definitely yes, you need to have an ICP monitoring. Mannitol, role of mannitol, yes. Therapeutic hypothermia or targeted temperature management, initial 24 hours. Now the evidences are decreasing, maybe in the next ACLS guidelines we'll have a different approach, but as of now, yes, we should recommend targeted temperature management following a cardiac. Coming to the complications, death occurs basically due to the ARDS, multi-organ dysfunction, sepsis syndrome, and post-hypoxic encephalopathy. So these are the main reason why death occurs. And there can be also other complications like pulmonary edema, hypoxia, cerebral edema, raised ICP, hypothermia, sepsis, DIC, shock, myoglobinuria, and hemoglobin, etc. And we have a small conclusion, because a lot of people are preparing for NEET. So there can be forensic autopsy finding of drowning, aspiration drowning medium in length. You can get the aspirated drowning medium in length, and you can get the weeds or sand in airways. White or blood tinged froth at the mouth or nostrils can be seen. Frothy fluid in conducting airway. Large and bulky, it is not kidneys, it is lungs that completely occupy the pleural cavity. Sorry for the typo. Brick red appearance of the cut section of the lung with large quantity of edema. Palatose hemorrhage, that is again one of the NEET question. It is basically a subpleural hemorrhage. You can see pink lungs in fresh water and bluish red in salt water drowning. What is the significance? I don't know, but this question might come for your NEET PG exam. So palatose hemorrhage, you can remember. Absence of water in the stomach again suggests either rapid death by drowning or death before submersion. To conclude, we have a beautiful flowchart that I have taken from the BMJ position paper. So in a nutshell, the diagnosis and the management of a drowning victim can be seen from this chart. Initially, check for responsiveness of the victim response. No response, open the airway and check for breathing. If breathing, perform pulmonary auscultation. If not breathing, give 5 rescue breaths and check for carotid pulse. That is the priority. If pulse is absent, obvious physical evidence of death, rigor mortis, everything is there. That's it. Forensic evaluation. If there is no pulse but there is evidence, no obvious physical evidence of death, it is grade 6 again. So start CPR as per the guidelines. Whatever recommended is the ABC sequence. And if there is pulse present and it is grade 5, then it will become grade 5. That is no response with pulse present. Start artificial ventilation, your endotracheal intubation, the management of your airway breathing, and shifting the victim to your intensive care unit. And now we will come to the response. The patient has got response. Perform pulmonary auscultation again. Again, it is divided into abnormal and normal. So if it is abnormal, rails in all area, again with hypotension and without hypotension. So with hypotension of shock, Again, the management is the airway breathing, circulation. You have to give adequate fluid resuscitation. Again, admission into the intensive care unit. And there is normal blood pressure. Stabilize your airway breathing, circulation. And airway and breathing priority is here because circulation is already okay here. So A and B stabilization is the priority. And abnormal again rails in some, only in some areas. So he has got just a grade 2 drowning. So maybe just an oxygen and antibiotics and other care will be sufficient. Maybe you can keep him in the ED for some time observation, and maybe you can later on move to the ward. And you have a normal lung feels, again with cough, without cough. Both is grade 1. With cough is grade 1. Without cough, he don't have any other major symptoms. So he can be, ideally as per the guidelines, he can be immediately asked to go home from the scene itself, but that won't happen in India. So we'll keep him under observation. So again, with cough grade 1, advanced medical attention and oxygen should not be required. So he can be asked to go home or keep under observation. So that is in a nutshell regarding the drowning management. So depending upon the victim's response, again you divide into no response and response category, and with pulse and without pulse. And to this side, depending upon the pulmonary auscultation, abnormal and normal, you have divided. So basically with this grading system, you can easily remember the management of drowning. I hope it is clear. So as I told before, I have used multiple references for this presentation from the ILCOR guidelines, from the New Zealand guidelines, from the Australian guidelines, from the BMJ position paper, and ABC of resuscitation from Willis. So these are my references, and also from Dynamed. Thank you for your patient listening.